There are a couple of challenging situations in IL power calculations, and some of these have already been discussed in the course of these presentations, and Subin is going to talk about the extremes of the eyes. One challenging situation is the post-vitrectomy cataract. There are actually 4 hurdles to overcome in these situations. Axial length determination can be really difficult, particularly with a posterior segment silicon oil field. And then with a plethora of intraocular lens formulas, newer formulas coming up, so which formulas do better in these eyes. And once that is sorted out, and then what exactly is the IL power we're going to use? Because we know that if silicon oil is kept in the is in the posterior segment, there's a hyperepic shift that happens. And if the silicon oil retention is planned for a long period of time, then how do we modify the IL power that is implanted? And of course, you have to use an appropriate intraocular lens. We don't use it, and the silicone lenses are no longer available. So hydrophobic acrylic single-piece lenses are the best lenses. So the most important cause of error in IL power calculation in these situations is basically the difficulties in axial length measurement. Error in axial length measurement can arise because of overestimation of axial length in silicon oil field eyes if you're using ultrasound biometry. Underestimation of axial length in eyes with macular edema when axial length is measured again using ultrasonic biometry, and underestimation of the length when ultrasonic biometry is used in patients with rhegmatogenous retinal detachment. So it would be best to do a prophylactic step. So whenever we have a patient who is scheduled for vitrectomy, we invariably perform an optical biometry if that is possible, and if it is not possible, then we do an ultrasonic biometry. And the results are archived in the hospital, and a copy is also handed over to the patient for safekeeping. Now, there may be situations where a patient has been operated elsewhere, there is silicon oil field, and we don't have the axial length data. So I would perform an optical biometry in the silicon oil mode and get my values. But optical biometry may not work in certain situations where if the patient has fixation issues, if there's an advanced or total cataract or thick posterior subcapsular cataract, then you have to perform an A-scan biometry. And here the real problem starts. Because we all know that in ultrasound is attenuated by the silicon oil in the posterior segment. You get poor retinal echoes. There are reduplication of echoes as you see here in this slide. So, and whatever axial length you get, that is an apparent, and that has to be converted into a true axial length. So this is actually a slide from Warren Hill. So here, this patient, he has used a velocity of 1532 for the entire measurement, and then the axial length that has been calculated is 36.28. And then when the correction factors have been applied, then ultimately it comes down to 25.69 millimeter, and which tallies quite well with optical biometry results. So there is a way of getting around these situations. There are certain situations where you have silicon oil half filling the posterior segment, and you cannot do an ultrasonic biometry in those patients. So it is when the patients are supine. So it is a good idea to keep the patient sitting and then perform a ultrasonic biometry. And in certain situations, nothing seems to be working. So what has been described in the literature is you can do a CT scan or MRI or go by the axial length of the fellow eye, use a standard power, which I really won't recommend, or you can get the investigations done after the silicon oil removal. Say, for example, after the silicon oil removal, intraoperative biometry can be done after pressurizing the globe with an infusion, and the results seem to have been pretty accurate. I don't have any personal experiences, but that is one of the things, one of the options. Second option would be to, after the cataract surgery, perform an intraoperative retinoscopy, and then use these formulas to calculate the intraocular lens power that is to be used for these patients. Now, the next thing is how do we select the IOL power? If you have silicon oil in the posterior segment and you don't plan to remove the silicon oil in the near future, because silicon oil has a different refractive index, so it always results in a hyperic refractive error, and this is actually accentuated depending on the lens shape factor. So if you have more carved posterior surface of the lens, the post op error will be more, and it will be less if you have a plano posterior convex lens, which I think is not available in the foldable lens format today, and meniscus lens would be the best. So actually, if you see the Warren Hill site, so he suggests the use of a lens which is 3 to 3.5 diopter more if you get to implant a plano convex lens with a plano surface facing posteriorly. And if it is a biconvex IOL, then basic rule of thumb is for lenses more than 20 diopters, add 8 diopters. For lenses between 15 and 20 diopters, you add 7 diopters, and add 6 diopters for lenses between 10 and 15 diopters. And these are all the situations where the silicone oil is retained in the posterior segment after the cataract surgery. And these results have been corroborated by a couple of studies as I've shown here. Now, as regards the newer formulas, and which is most ideal. So there are different scenarios when you do cataract surgery in a vitrectomized eye, or cataract surgery in a vitrectomized eye with silicone oil retention, and then patients switch where you do cataract combined phaco with vitrectomy and membrane peeling, etc. So what are the new formulas? So there are various studies which compared the new generation formulas with the traditional formulas. New generation formulas excluded were Hill, RBF, Olsen, and Holiday in these particular studies. And it was seen that, for the new generation formulas, did extremely well for all these patients where cataract surgery is performed in vitrectomized eyes. And traditional formulas, as Dr. Dowd had already mentioned, with Bangkok adjustment, had also done extremely well. Now, when you're doing a combined phaco with silicone oil removal, again, the EVO formula appeared to do best for these kind of situations. And when we do a membrane peeling, vitrectomy membrane peeling and for epiretinal membrane, then Kane formula seemed to have given the best result according to this particular study. If you have a patient with a macular edema and somehow, optical biometry has not been possible, and you have done a ultrasonic biometry, so it is been our experience that you get a postoperative residual myopia in these patients. So it is a good idea to reduce the IOL power by maybe about 0.5 diopter. So friends, in conclusion, there are intrinsic challenges to full visual recovery in eyes with posterior segment pathologies. In spite of that, you should make all efforts to optimize the visual outcomes by resorting to the latest technology techniques, the current concepts, and the newer formulas. So thank you very much for your attention, and I would request Suven to talk on extremes of eyes.